afternoon. So we are now going to hear from three ADVAC alumni of very different background and career. The idea is to ask the alumni to talk about their career, how ADVAC actually impacted on this career or not, and how they see the future of vaccinology and any challenge that they have encountered in their career. So they had carte blanche to deliver their presentation, and then we will open for discussion. One of the three person, Shabir Mahdi, will only join at 3 p.m. So we will start with hearing from Anne Lindstrand, who was in the class of ADVAC in 2014. Then we'll hear from Kamel Senussi, who was in the ADVAC class in 2010. And then we will hear from Shabir, who actually was in the first ADVAC class ever since he attended ADVAC in the year 2000. I will not introduce this alumni for the reasons that I just mentioned. I am asking them to introduce themselves. Of course, you have already had Anne introduced, but I want them to describe who they are and the flow of their career. So with that said, then I will turn to the first of our alumni, to Anne Lindstrand. So Anne, please.
Delighted to be here, all ADVAC friends. It's a fantastic opportunity and challenge to just have carte blanche from Philippe and be able to reflect on what, what did ADVAC do to me and my life. And so thank you for that challenge, Philippe. And I hope we'll have a good session together. I don't know. I'm sometimes, so I'm Anne Lindstrand. I'm a pediatrician, and I work as unit head of EPI at WHO Geneva now. But I'm always amazed that my kids and the friends of my kids, many of them have a really good pathway. They know exactly where they want to go, and then I'm going to this school, and then I'm going to this school. My life hasn't been like that. I've tried to, sometimes I've tried to be serious and just make a career choice, and this is the way I want to go. But most of the time I've just jumped on occasions and just, followed my heart. So kind of this is my path before I came to ADVAC. So a little bit of a crooked path. You see on the left-hand side, can you see when my arrow goes so I can follow you? You can follow me. Yeah. Yes. I can see some noddings. Thank you. So after high school, I went to University of California. A great place, lots of fun, university life, vibrant international community, lots of discussions, historic political place. I had so much fun. I was 18 and studied, third world studies, peace and conflict studies, history of art, things that really, made my life fun. After that, I had another path. I really wanted to do something and try. Where am I going in life? And so I went to India. I was 20 years old. I worked for Mother Teresa in Calcutta and in several different places of her different homes. Not by religious faith, but really, she was living with the poorest of the poor in the slums of different places in India, gave up her life to be able to give dignity to the poorest of the poor. It was a life-changing event. Of course, at that age, you do change quite a lot. I came home unbearable idealist and tried to give away the whole family, you know, treasures we had and everything. And everyone was just saying, good God, eat the turkey at the Christmas dinner now, Anne, and shut up. And so after that, I went over to Switzerland to learn French. I spent 8 months working in a laboratory, skied a lot, and French really has helped me quite a lot during the rest of the path, what I did. Into medical school in Sweden, took a break in medical school. I went through on an overland truck across Africa, living in tents and go all through East Africa. It was good. Worked on fair trade when I was in medical school, still in a shop there. And then I found my place of heart, Mozambique. I went back and forth to Mozambique, and I've done that so many times in my life. I did a research project as medical student. It was a good time as well to stay longer in a country trying to understand. It was war-torn, beginning of the 90s in Mozambique, still with the war going on, but in Maputo, you know, still possible to live and breathe and be pretty free. I started, finished medical school, started to work as a pediatrician. So when I was done, I was doing the first trip to work with with MSF in Angola. No, sorry. I'm changing my mind here. So in Mozambique, I went back a few times. Sorry, I'm getting confused with my own maps here. I went back forth for consultancies, different work in Mozambique on and off. And then I met a very important person, a professor that I worked with for many, many years, Hans Roosling. He is a crazy statistician professor. He passed away, unfortunately, 2 years ago. But we planned and did a lot of courses, so public health courses, where we brought medical students, nurse students, midwives, etc., in a global health course. And we had half of the course in Sweden and half of the course with collaboration in India, Cuba, Tanzania, and every other places. So I traveled a lot, and I don't know any better way to learn public health than, you know, by a public health, junior public health nurse in India, and sitting and listening to you know, a nurse under the tree in Tanzania, and also be able to, you know, work as a teacher. It was very good. I went to Harvard School, did my MPH, and then I did a lot of years with MSF, Médecins Sans Frontières, Doctors Without Borders. I was both in the field, but also on the board of the international organization as a president for some time, and also trying to set up the full structure. We started like in a little office in Sweden, and then expanded and it's now a huge organization. Sorry. There we are. When it comes, and then when I took the chairmanship, the presidency of MSF in Sweden, it was the same year as we got the Nobel Peace Prize. So I think, I don't know how many ADVAC alumni have taken the Nobel Peace Prize, but I'm one of them. And I was terrified because you had to speak to, you know, the king and the queen and everyone to in the process. Went back in cholera epidemic in Mozambique, and then I also worked 2.5 years in French Guyana as head of MCH services, which was absolutely fantastic because it was a small place with everything under the sun, public health wise. We had 28 health centers, and some of them 8 hours by this boat to get to. Fantastic job, really, really interesting. And it's it's part of France, but it's really everything else than France in one cooking country. Then I started with my research, and in Uganda, in PCV, I was looking at carrier studies before the PCV introduction in Uganda. I also had studies in Sweden on the introduction there and what has happened. And then came ADVAC. So that's my dwindling little road towards ADVAC. And then ADVAC. It was 2014, as Philippe was saying. And I'm really, you probably heard this to death, but sorry that you couldn't experience the being in Fondation Mérieux, peaceful, lovely place, excellent food, and incredible lecturers. For me, it was like the scientific superheroes on stage. I was absolutely starstruck by the people that I've read articles from. They were there in front of me. It was just fantastic. Discussions late at night, walks at the lake. But also what I liked and what I've tried to keep up in my own teachings is the interactive, playful, inspiring, impactful, the way of learning. I think I'll never forget the media training when the person, strips from one dressing to another one on stage and really shows physically how that has an impact on people. So it was a time of a pause and rethinking. And so what happened? Well, after ADVAC, it was full-on vaccines from my side. So I went back, I worked in the Public Health Agency of Sweden, first as vaccine expert and then specialist, and then as the head of the EPI program. So EPI manager, if you say so. We had lots of challenges in Sweden, believe it or not. I came, in 2014-15, there was remember the influx of lots of migrants having to find and trace and catch up vaccination for them. There was vaccine shortage of BCG and other vaccines coming on and off that we were having to fight and do new guidance, support, and etc. I developed the rotavirus dossier for introduction in Sweden. I started up the NITAG work, and was the chair the first years, and then we worked on the HPV for men. But my heart was very much in a small project that I started and I did for the rest of the time that I was there, which was about trying to understand why the Somali community in northern parts of Stockholm really had a lousy coverage. And understanding and working lots and lots and lots on the ground with the peers, with the nurses, the local communities, the religious leaders, and trying to understand the reasons why they were under-vaccinating and how to best be productive and reach them. I really learned how behavioral change is not a quick fix. You need to work, shoulder to shoulder with the nurses. You need to work shoulder to shoulder with the community itself. Not unlike at all what I have, experienced when I worked with MSF and other places. So, and then somehow, anyway, Sweden became very small. 98% coverage, all pathogens, flatline since forever. Almost, and I really, really long to get out in the world again. So I applied for WHO and I got the post as unit head and started in September 2018. And so I came to the EPI program, the Essential Program on Immunization, as we call it now in WHO. And it felt like I was coming to swim with the dolphins. I really, really loved love to work in this program. There is a bunch of highly competent, passionate people, super productive, friendly and fun people who care about immunization. And so it is really, really a privilege for me. The last 2.5 years on the left-hand side, we've worked a lot on understanding, the global challenges in immunization. what are we facing today, and then redone and worked on different strategies. So on the right hand side, you can see some, how they link together, the Gavi 5.0 strategy, the immunization agenda 2030 strategy, and at the same time we were restructuring and doing something else about immunization in WHO. So it looks really orderly, right? It looks like we got it all. And this is, you've already seen this, the vision and strategy, the immunization agenda. I think we have a good case, and you in this course, you've been exposed to all of the different strategic priorities. I heard you were talking about UN challenge studies and other research topics, but you've been exposed to the full picture of important new direction for the world in the IA, in the immunization agenda, not the least the core principles, and I'm coming back to those. So what we tried to formulate in this new immunization agenda 2030 was a really new way of doing it. So the bottom-up approach, we'd really try to have extensive co-creation of the strategy itself. Tailor it and not have one size fits all. And then you have all these different areas. You can just read them. These are the things that we have really primed and said these are the new directions that we want to take the immunization agenda. Okay, so all fine. We had that, right? We had the strategy. We knew where we were going. We knew we had challenges before the pandemic. But we have the IA 2030 as a crutch to try and say, okay, this is the way we go. We are all in the tornado right now, right? Our lives have been set upside down. You're virtually having your ADVAC course instead of being in that blissful place in Fondation Emerieux. Coverage has been dipping and coming back a little bit, but not to the extent we wanted. So we are moving towards the after pandemic, and we've tried to work with maintaining and restore, catch up those kids that are in the dip page on the middle slide on the below, build back better, and the PHC as the cornerstone. But I also think the global health security will be one of the key things that we need to rethink, well, totally after this pandemic. And at the same time, we're still in the tornado. And look at this slide. This is the global chart of vaccine introductions in the whole world. So you see from 1990 to 2022, there is no other vaccine that has been introduced in all countries in such a short time. This is like an endeavor of never ever seen pace before. And the only one that can resemble something of it is the IPV, which was around mid 2010s, where a lot of countries introduced, but it still took several years, right? So the COVID-19 vaccine it's putting an enormous strain on immunization programs in one single year, more or less. And as you remember, we have discussed, more or less everyone has introduced already. So just a few reflections and slides before I stop. I think the one key thing that is in IA 2030 and that is also linked to the COVID-19 vaccine rollout is the life course approach of stop thinking about immunization as something that drops dead after childhood, but really is a continuous life. And you have many chances. We need to think of immunization as not, one off and then that's it, but actually having a possibility to reach and re-reach and re-reach and give every person a chance later on in life. And so the life course approach of understanding what in each year and how we can build platforms like where the world is racing right now to do the platforms for reaching elderly and healthcare workers, which we are not very good at anywhere, actually. A systematic, very good healthcare worker program, or if we have one of elderly populations, we have a lot of work to do in high income, as middle income and low income countries. So I think this is one key. but also about working together with other programs, loading and seeing what is in the need for people, and what are their wants and desires when they come to a healthcare center, not just vaccines, but looking at it at a much broader way. We need to link up and think about partnership and how we work with other programs. And this is an area where I work quite a lot right now on innovations in COVID-19 vaccine rollout. So I think we have a lot of opportunities. The digital age has not reached immunization yet. And there are many reasons for that. And you can't leap this in 1 second, but there is an opportunity with a lot of attention and funding and need to be efficient in the COVID-19 vaccine rollout, that we could use some of the tools that are mature and that could help the implementation rollout in microplanning, in counterfeit, in vaccine status, vaccination status monitoring, safety monitoring, and infodemic. And it's being rolled out. It's being rolled out very, very fast. So coming back to the vaccinology, I mean, the core principles of IA 2030, I think another piece that we see moving now is the data guided, and how we need to be much more better in the granular planning. Use maybe digital microplanning, maybe not, but it could be an opportunity now to understand and classify where are the health centers and where are the populations missed. Can we link that together with triangulating the surveillance data, with coverage data, with where people are, and find out where we should be and move in the next implementation. Another piece which I take with me from the Somali community and from all the MSF years is the people-centered services. I think we're moving away from so singularly looking at the supply side to understanding the full picture of a family and their needs, and being able to structure services in a quality service-centered way, and serving the populations rather than building services and just make them, people think that they would come anyway, unless we have a good feedback loop and understanding the concerns of people, and how they are received, and what opening hours there are. And I think we can reach that higher coverage if we do tailor this in another way. The partnership principle is also something that I work quite a lot on right now, trying to see how do we get from those vertical, all those vertical programs on the bottom. They've been extremely efficient, right? But are they the best way of delivering services if you want to be people-centered? Not really. I mean, you have a full person that needs serving, and you need to work with them. So we're trying to, squeeze them and see how we can work with them within the IA 2030 ownership and accountability structures, integrate them, and we work much closer, and learning from each one of them about this best surveillance methodology. And this one could be tailored into the next one, and how do we do more comprehensive work together. Finally, I think one piece that has been very important in the development of IA 2030 is the country ownership. I mean, when I work at WHO, it's not so easy, because you're constantly in donor discussions about, because WHO is poor in itself, right? So we're constantly in discussions with different donors about doing this and doing that. And then you end up with a work plan where you have piecemeal asks from this and that, and reports here and there, and so on. So a lot of my time as unit head, I need to manage donors. A country is exactly the same, right? You have all these vertical programs, the donor requests, this and that going forward. And I do think that the global landscape need totally to change. A changing, world order in global health, for us to be able to organize ourselves in a way that serves the countries, that simplifies for the countries, and And that can only be done if there is a good collaboration in the outer ring. So the global donors, actors, immunization partners get our act together and work much closer and close our loops instead of coming in with different asks here and there. There's a very good article in Nature where you have the link below, which was from Global South thinkers not long ago, which says the predominant global health architecture and its business enabling Western institutions more than to gain more than, and sometimes at the expense of the people, institutions of the countries where the actual problems are. I think this time it has finished with the global architecture messing up and giving headaches to many of the countries where they are the owners. So I think what we all need to do is think differently and really take it seriously. Finally, my last slide, I just wanted to say that I'm an optimist. You see the report on the right. It's being discussed these days in WHA. And it's a good reset after the pandemic, a good thinking about the global health architecture. How should we prevent the next pandemic, out of which vaccines is certainly one area, but it's not the whole. I think we as immunization people need to work at that global level to think about the global health and how can we contribute to the stopping the next pandemic in every possible way. So what it says is the pessimist sees difficulties in every opportunity and the optimist sees opportunities in every difficulty. And I'm definitely an optimist. I think this pandemic can help us. We just need to use the momentum of it and identify now that we see that a lot of resources immunization and global health security. And that's it. Thank you.
Thank you very much, Anne, for this incredibly inspiring presentation. I will actually not open for questions right now, as I prefer to go through the three presentations of all of you and then open for question and exchange, as I believe that otherwise there would be some redundancies. So, and I would now turn to Kamer and ask him to start his presentation. Please, Kamer.
Sorry. Can you hear me? Yes, thank you. So I'm sorry, I'm having some troubles with my PowerPoint, like usually. So I hope you see my slides. So I'm Kamal, and first let me thank Philippe and the ADVAC course for inviting me to share this moment with the students as an alumni from 2010. I'm very happy to be here because I was very glad at that time to have the opportunity to discuss with many different alumni from ADVAC and also the professors. It was very interesting to be able to share and discuss regarding their career and what they've done and how they reached the job that they were having. So I'm very glad to be able now to share also on my side what I'm doing. So maybe very briefly, as Anne did, yeah.
Perhaps you may wish to go full screen because you are still in the.
Okay, that was not working,
perfect,
so now it works. Perfect. So so I started as a medical student in Vietnam in '96, where I discovered infectious disease in developing countries, and I still have in my memory this kid, this baby with tetanus, which I've never seen before during my medical studies, and it really struck me how it was still possible that we have tetanus cases when we have a vaccine since a long time. So I decided during my residency as a medical student to do a public health residency, which is a specialty in France where I did my medical studies. I became a medical doctor specializing in public health. I decided to do during my residency a master of epidemiology, and after that a master in health policy and financing. So after that, I worked at the Ministry of Health in France, working on public health in France. And then I had the opportunity to join WHO as a junior program professional officer, JPO. It's a program where young professionals can join international organizations, and I was lucky to be able to join the Office for the International Health Regulations and Outbreak Responses. I did it in Lyon, where there is an office of WHO working specifically on supporting countries to implement the IHR, and then in Washington at the regional office for the American countries at PAHO. So that was very interesting. Outbreak investigations all over the world, and also supporting countries to strengthen their capacities for surveillance and response. So this was the IHR, revised IHR after the SARS outbreak, and the IHR were revised in 2005. After that, I joined an NGO called AMP, and I worked on the Gates Foundation funded project with WHO. The objective was to support countries all over the world to strengthen or to establish NITAGs. I believe that you had a session on NITAGs during ADVAC. So the program called CVAC was really supporting countries in Africa, in Middle East, in Europe, in Asia, to implement those committees and also to create this network with existing NITAGs. I'm not going to talk more than that. I believe that you had a full session on that one, as Philippe was heavily involved in this work. I joined after that, and I think I didn't put that in the slide. I joined the European Commission for 5 months. I didn't like it, so I resigned. And I joined WHO again, and this time that was in Geneva, working in the immunization department where Anne now works, and I was working in the director's office with Philippe and a few others, working on the Global Vaccine Action Plan Secretariat. So that was the strategy, the global strategy that was adopted after a huge consultation process called the Decade of Vaccine. The objective was really to develop a comprehensive strategy for immunization from research to implementation. So it included objectives, goals for coverage, for research, for vaccine adoption, demands, supply chain, everything. So this strategy was in place for 10 years, and it was recently replaced by what Anne just presented, Immunization 2030. So the work was at that time to present the progress made every year to the World Health Assembly. So to collect information from countries, from manufacturers, from civil society, from various partners, and to have like a very exhaustive report to be able to track the progress and to take corrective actions. And I also then after that, I did that for 4 years, and I then joined UNICEF Regional Office for Middle East and Northern Africa, and I was the regional advisor there. And I'm going to explain a bit later what was the work. And more recently, I joined the Gates Foundation, the polio eradication program, where I also do some work around routine immunization strengthening. So after this background, just to talk about ADVAC itself, you're close to the end, so you probably know most of what I'm going to say. But initially, I really appreciated one thing that I was missing, which was the immunology part, because my last immunology courses were from medical studies more than 10 years before ADVAC course. I was very glad to hear the eminent immunologists sharing how a vaccine works and how it works and how the immunity system works. So this was really something that I really appreciated. It was also learning about the vaccine research and the manufacturing, because this is also something that being a medical doctor and being more on the implementation side, I was not fully aware. So that was important to understand the rationale, the determinants, the reasons why manufacturers will go towards manufacturing one vaccine or to fund some research in one area. So the ADVAC course really helped me to understand that. But most importantly was also the broad vision that ADVAC was bringing in many areas that I wouldn't have thought about before, and having these large areas in sessions with the experts of those areas was very helpful to see that vaccinology is quite large and touches at different worlds and different expertise. Of course, the ADVAC course is a great network. It's really great to have access to those different partners from different organizations. You really have this ability, thanks to the ADVAC platform that probably Philippe and ADVAC course will present to you, to reach out to some experts, because you can really look for one expert in one area, in one vaccine. And this is really something that is unique. And being in the immunization world for more than 16 years now, I really appreciate this option of finding the right person when you need some very specific expertise. Also, having access to the courses is also very helpful, because I can tell you that after 11 years, you forget a lot. So it's good always to be able to go back to the online courses if you need to have a rapid update on one area. Not missing the social time spent with colleagues. Unfortunately for you, not this time, but hopefully you will be able to join as an alumni some sessions in Annecy at the Merieux Foundation to meet colleagues and lecturers. This is also a very nice part of the ADVAC course. And also, I want to highlight the fact that being an ADVAC trainee is really something that you should put in your CV, because this is a network and people appreciate the fact that you've been selected and you took the time to do the ADVAC course, because it really shows that you have a broad understanding of what is the vaccinology. And this is something that in my career, several times people pointed out that I was an ADVAC trainee. So that's something that you should put in your CV for any application that you're doing. And also, of course, you will see that time to time there are some post description jobs shared on the platform, and that's something appreciated. And lastly, friendship. You probably met colleagues, other students and professors that will probably be friends for your entire life. That's my case. I met many of my very good friends at ADVAC, and we kept in touch, and we are still very good friends. So that's also something that I appreciate from the ADVAC course. So what I wanted to share now is more after the ADVAC course, what was really, what are the different aspects of the work that I've been doing thanks to ADVAC. So the first one is really the work on the norms and standards and the policy. As I mentioned, on the left, you see the Global Vaccine Action Plan, which was this strategy for 2011-2020. And we, as a staff of WHO immunization team in Geneva, my role was to support countries and regions to develop their own national plans and regional plans. So, of course, my medical background was very helpful, but what I also acquired during the ADVAC course helped me a lot to understand the differences between the countries when it came to develop their own plan. you don't have the same plan if you're a low-income country or if you're a high-income country. You don't have always the same problems, or even if you have the same problems, the determinants are not the same. So it's very important to be able to have this understanding, to be able to support countries differently and regions differently. And then, I mean, the other part was, and you see on the right side of the screen, the annual report that we were preparing to monitor the progress made by countries, by regions, by partners regarding achieving those goals of the Global Vaccine Action Plan. It was important also, again, to understand why, for example, we were not making progress in one area like supply chain. What was the problem? Was it the funding? Was it the material? Was it the pre-qualification? Was it the availability of manufacturers? So all those kind of things were helping a lot when it came to discuss solutions for those issues. And again, ADVAC was quite helpful for that. So after the norms and standards, I wanted to highlight an important element of our work is the policy and advocacy. We spend, and it was the same at WHO, at UNICEF, and now at the Gates Foundation. We spend a lot of time doing advocacy and trying to advocate for governments the need to invest in immunization, because it's not always fancy anymore. For many middle-income countries or even low-income countries, they want to focus on other things like chronic diseases. They want to feel that they are part of this transition, this epidemiological transition. So you have to go back, you have to talk, you have to explain why investing in immunization is so important, and that will bring them huge benefits because it's highly cost efficient, as you probably discussed during the ADVAC course. So it's really meeting head of states, meeting ministers of health, trying to get, like you see on the left bottom, partners. Anne mentioned that if you have in the same room, like you have in this picture, WHO, Gavi, Gates Foundation, World Bank, and others, if you have all those people in the same room talking to a president, in this case, the president of DRC, it really shows to the country that those partners are willing to collaborate to support the vision of the government. So bringing everybody around the table and collaborating is not an easy thing, as Anne pointed out, but that's something that we can achieve. And I think that having been an ADVAC person, where you meet people from different institutions, really make you understand what are their determinants and why they act like they act. So it's better than to make them meet. So this is a critical part of the work. Another element that I want to mention is the field assistance, the field technical assistance. It really means going in countries and looking at the reality of countries. So I took here an example that may be sometimes a bit extreme, which is remote areas in DRC, DR Congo. Access is difficult. You don't have roads. You don't have. It's rainy season. The fridge is off, is not working since several months. There is no supervision of the healthcare workers, and there is no electricity, no telephone network. So it's really to show that we need to also all the time think about how we're going to implement the policies that we are developing at global and regional level, and even at national level, because the reality in the field is sometimes difficult. So it's always good to go back to this reality when it comes to provide support. Another example of the work that I've done is to support immunization in emergency context. So being an ADVAC, you also hear about policies and strategies that you never heard before. And that's something that is quite helpful. For example, on the left, when it came to advocate and convince the authorities of Iraq, which was in big crisis, both political because of the instability, but also economical crisis because oil prices dropped hugely, so they were not able to pay for the vaccine anymore. So having the opportunity to present, for example, the work of UNICEF Supply Division and the facilities that they offer for countries in crisis was a key element to ensure that countries have access to vaccines. at a good price. On the right side, it was discussing during Syria war, discussing with both sides, the government, of course, but also the opposition, and trying to find a consensus and agreement on how we're going to share the vaccines that they have to ensure that all kids are vaccinated wherever they are. So this is part of the work that we do during emergency. And also being in a multicultural environment helps a lot to manage those diplomatic discussions. This is again the field assistant. Sorry, I swapped 2 slides, but this one is also to show that again, you have to go to the field, you have to look at the reality, you have to talk to the mothers, you have to talk at the healthcare workers to understand what is their reality when it comes to do immunization, because it's sometimes easy to do recommendations, but the reality is much more difficult, and you have to understand why they do like they do. And lastly, I wanted just to show, as Anne showed, some innovations that, for example, at Gates Foundation, we're trying to push the use of drones, the use of those vaccine carrier that you can carry for days without having to fill ice in it, those fridges that work without electricity for up to 5 days. Anne already mentioned the use of GIS for micro-planning. We did some work in some countries, and we discovered that in their mapping, they were missing a lot of kids because villages were not even in their maps. If you look at the previous maps on the right side, those are real maps that are used by healthcare workers. So we try to use now GIS and try to identify those villages and make sure that they go there. We even use vaccine trackers in their phone to check if people go there, and even training on the phone. So we try to use those technology that will not solve the problems, that will help the healthcare workers to address all those problems. So lastly, maybe a few thoughts regarding vaccinology in the future as I see it. I really believe that we are still missing the field aspect of it. I mean, everything else is quite well developed, but I think we need more understanding and more inputs from the people from the field. I really believe we need to involve them more in, for example, even in the ADVAC course. So they really explain, as I mentioned several times, their reality. So their reality will help us to adopt and to adapt the strategies, the product that we are using to be more useful and easy to use in the countries. And some areas that I feel we are still missing a bit here, the vaccine management. It's true that we have the tendency to think that this is another part of, this is not vaccinology, this is supply chain, people, specialists. So I think we are missing a point here, that we are not investing more into thinking how we should distribute vaccines, how we should change the cold chain to take into account the specific needs of countries, because for now it's a bit too, people think it's just a problem of money, and I think it's really rethinking the whole thing. And I think some partners have started doing a lot of work in that, like UNICEF and a few others. And I think we, like Village Reach, and I think we should probably work more and include that more into our understanding of the vaccine management. Economics and finances, we are seeing now the impact of money when it comes to buy vaccines from the manufacturers. This problem of countries fighting to get vaccines, access to COVID vaccines, the COVAX, for example, but we need to have a long-term work on that, and long-term thinking on what works and what doesn't work. Some regions of the world have the pooled procurement, like PAHO, but some others tried to do it and they failed, like the Middle East. So we need to work more on that and try to understand what would be the best solutions. And I think this is part of us missing the whole discussion around the price of vaccines, the ownership regarding the origin of vaccines. This has to be probably more discussed. Vaccine hesitancy, I'm not going to talk about that because I believe that was mentioned many times during this course. Social media is key, and I even heard in the previous session that was also discussed. Vaccine platform, the new vaccine platform, we have this new platform of mRNA, and it's probably going to open many new doors, many new vaccines. So we'll probably have to see if those vaccines are better than what we usually have, and do we have to change even, I don't know, the DCP, the pentavalent. We will have to reevaluate what we are doing with those traditional vaccines. So that's something that we probably have to include in our discussions. And last thing, new partners. You heard about WHO, UNICEF, Gates Foundation, and a few others. I think we have a lot of new partners that are interested in investing in immunization and vaccinology. So we probably need to make an effort to include them more. I'm thinking more about regional economical organizations. Many of those organizations and their associated development bank are willing to do something. And for now, I mean, I feel that we are not doing enough effort to bring them into the discussion and the dialogue around immunization. Global networks of regional courses. I believe that ADVAC is great. I love it. But we probably need a specific ADVAC for regional, for the Africa region. If there is one in South Africa, I think it should probably expand because there is a big need. And my last complaint, and some of people who know me know that I'm always complaining about that, the language. Not all our colleagues speak English. So we really need to make an effort on the language and being able to develop those courses in other languages so people can have access in their own language, so the impact will be bigger. Let me stop here and let it to Shabir if he's online. Thank you.
Well, before turning to Shabir, so thank you very much indeed for another, Kamel, for another inspiring talk and journey into the challenges of delivering the vaccines to the arm of the people. I will indeed now turn to Shabir, keeping the questions for all three of you at the end. And Shabir, welcome. You just connected. Initially, I indicated that I will not introduce any of you as this is part of your presentation to tell participants here about your career. So I just told the participants that you actually attended the first class ever of ADVAC in the year 2000. So thank you very much for joining and taking from your busy schedule, Shabir, and on to you then.
Thank you, Philippe, and good afternoon, everyone. Are you able to see my screen?
Yes, we are. However, could you move in a full slideshow mode? Okay, perfect. No, you. No, we are in a note mode. So display setting. Go to display setting.
Okay, let me try again.
Share your screen.
Are you able to see it now?
It's still not in a slideshow mode, so if you could.
Yeah, full screen, please.
Yeah, perfect, perfect. Thank you.
Okay, great, thanks. So thanks and good afternoon, everyone. And it's a real pleasure and privilege for me to be invited to share with you some personal reflections on what I really consider to be an accidental career in vaccinology. So as Philippe mentioned, I was privileged enough to attend the very first advanced vaccinology course. And I just sort of highlighted my place in this huge group of people, many of whom were pretty much people that I very much looked up to and never imagined that I would have an opportunity to meet, let alone to hear them impart their knowledge to me. And that was way back in May in the year 2000. And thanks to Betty Dode, who was then the scientific coordinator for ADVAC, for sharing this particular photograph with me. So this particular photo was actually taken at a gala dinner that took place right towards, I think it was the second last day of the 14-day course. And one of the most memorable occasions at that gala dinner was, in fact, the recognition of Prof. Claire N. Segrest being inaugurated a year earlier as the first professor of vaccinology at the University of Geneva. And if my memory serves me correct, it was mentioned that she was the first person to actually hold this title of Professor of Vaccinology. I might be mistaken, but that is what my memory serves me. Now, for someone that came from a country such as South Africa, where there was very little activity taking place in the field of research when it comes to vaccines, except perhaps a little around implementation, I found it quite intriguing that someone could actually assume the title and develop expertise to assume the title of Professor of Vaccinology. And this has stuck in my mind for many, many years since. And certainly not expecting ever to be conferred such a title at my own university, it just remained a thought. Now, my introduction in the world of vaccinology really was somewhat fortuitous in that in 1996, when I completed my training as a pediatrician, opportunistically, there was a vaccine trial that was being planned in South Africa, and that vaccine trial was on pneumococcal, a pneumococcal conjugate vaccine trial. And one of the lecturers that you probably heard from during the course of the past few days was Kees Klugman. And Kees was at that stage in South Africa, the head of the South African Institute for Medical Research, and he was taking on the task of doing the first vaccine trial outside of the United States on a pneumococcal conjugate vaccine. And this was being done in a country which historically has had a history of doing the very first vaccine trials on pneumococcus, which date back to the early 1900s. And since then, a number of the pneumococcal vaccines, the polysaccharide vaccines, as well as the wholesale vaccines, were actually first evaluated in South Africa before they were evaluated in many other, in even high-income countries. So Kees was really continuing in the footsteps of giants in the field of research around pneumococcal vaccines. So when I completed my pediatric training, this opportunity came about. And in fact, what had happened is that Kees had already identified a suitable candidate to lead the clinical component of this vaccine. My own background was, as you can imagine, just having qualified as a pediatrician, was pretty much no experience in vaccinology or even in research. It was something that I had just done, knowing that basically I wanted to be a pediatrician, but not knowing what I wanted to do beyond that. So Kees was then convinced by the head of the Department of Pediatrics that perhaps he should actually consider other candidates for this particular position. He advertised the position, and I was prompted to consider applying for this position. And inadvertently, what ended up happening is that someone with absolutely no background and no experience in research was asked to take on the clinical lead role in this vaccine trial, where we enrolled close on to 40,000 individuals. As I'll show you, the results of the vaccine trials were somewhat pivotal when it comes to the WHO having made a recommendation for the introduction of this vaccine into immunization programs, especially of low and middle income countries. Now, one of the other important learning lessons from this initial experience for the pneumococcal conjugate vaccine was never to always listen to your supervisor, because you would probably allow for opportunities to go amiss. Kees, being a microbiologist and having a strong interest in pneumococcus and other bacteria, required a fair amount of convincing when I mentioned to him the opportunities of actually exploring what the impact of preventing pneumococcal disease would be on admissions for respiratory viral infections. And his bottom line was, well, it might be of academic interest, and if it was something that I was wanting to pursue, then I should just look for the funds and perhaps test all his children that were being admitted to hospital for respiratory viruses. For me, perhaps one of the most important learning experiences from this vaccine trial, other than showing that a vaccine prevented what was then the leading cause of death in children was allowing us to use this study as a probe to delineate the interaction of respiratory viruses in contributing to of pneumococcus as a superimposed infection in children that were initially infected with respiratory viruses. So one of the findings of the study was where we demonstrated that you were able to reduce hospitalization for RSV, influenza, human metapneumovirus associated LRTIs by closer to 30 to 35% by vaccinating children with the pneumococcal conjugate vaccine. And obviously the basis of this is not that you prevented infections from those respiratory viruses, but you prevented the superimposed infections from taking place. Now, I was probably naive to believe that I was going to stay on and do a little research on pneumococcus for a period of a few years until the vaccine trial was over and pneumococcus will become a problem of the past. Because as we all know, 21 years, the first pneumococcal conjugate vaccine was licensed in the United States in the year 2000. And in 21 years later, there's still a huge amount of work taking place in the field of pneumococcal conjugate vaccines. Be it looking at higher formulation of vaccines, be it looking at alternate dosing schedules, be it getting a better understanding in terms of the effectiveness of the vaccines and how that actually differs, looking at high-income countries and low-middle-income countries. So as an example, when looking at the effectiveness of pneumococcal conjugate vaccine, especially in terms of its indirect effect, in many high-income countries, many of these vaccine serotypes have largely been close to eliminated. Because of high penetration of the conjugate vaccines in children. Whereas in low middle income countries, where the dynamics of transmission of pneumococcus vary tremendously compared to what exists in high income countries, even in a country such as South Africa, 12 years after having introduced a pneumococcal conjugate vaccine to the public immunization program, we still see high prevalence of colonization by many of these vaccine serotypes. So one of the other important messages here is that we simply can't be in a situation where we try to determine policy and recommendations for low middle income country settings based on studies that were done in high income country settings. Because there are fundamental differences in terms of the dynamics of many of these infections. And certainly, as I'll show you later, when it comes to SARS-CoV-2, COVID-19, probably not very different. Now, at this particular meeting, I was also fortunate enough to meet another lecturer, Roger Glass, who was the person that knew everything that had anything to do with rotavirus and rotavirus vaccines. And this was at a time when the first rotavirus vaccines were coming close to being introduced in public immunization programs. And fortunately for me, unfortunately for me, Keith left South Africa in the year 2001 and went to Emory University, and Roger Glass at that stage was also at Emory University. So I had some brief opportunities of chatting with Roger Glass at the ADVAC meeting. And 2-3 years later, Roger made a visit to South Africa and asked to meet with me. He came to my research unit and we had a brief discussion. And in a few hours, he was able to convince me that there was more to life than just pneumococcus, and that diarrheal disease was an important role player in childhood morbidity and mortality, which I really understood being a pediatrician. But he also got me interested in terms of considering doing studies on rotavirus vaccines, again, for the very same reason, in that although the studies were being done in high-income countries, the question remained as to how well these vaccines were going to perform in low and middle-income country settings. So that culminated together with Catherine Neels, who's another lecturer that I think you've heard from, in us doing the first studies of the rotavirus vaccine in Africa, which was a study done in South Africa as well as in Malawi. And the interesting features of those studies was that although, as an example, efficacy of the rotavirus vaccine in Malawi was only about 35 to 40% compared to 70% in South Africa, when it came to the public health impact of the vaccine, there were about 3-fold more cases of severe diarrheal disease that were prevented in Malawi compared to South Africa, simply because of the much higher underlying burden of disease that existed in Malawi. Now, another important lesson for me for COVID was the huge value that is actually added in terms of my learnings when it came to vaccinology. And since having attended, I've been encouraging, and I've always encouraged a number of other more junior staff in my research unit to apply to attend to COVID. And this is one of those individuals, Michelle Groom, who subsequently did a PhD in my research unit, and she is also an alumna of COVID. And since then, she's been leading and had led much of the rotavirus vaccine work, including currently looking at the development of the next generation of subunit rotavirus vaccines. And this is a theme which I'll come to, where a number of other individuals from my own research unit have had benefits of attending the ADVAC course. As I mentioned, my field has mainly been focused around epidemiology and clinical evaluation of vaccines, but those sort of activities have largely impacted and have been foundational to recommendations on the part of the WHO for the introduction of both pneumococcal conjugate vaccine as well as rotavirus vaccine into public immunization programs of low middle income countries. And certainly from a country level, because of the type of work we've done in South Africa, it very much provided comfort to the government to be amongst the first, in fact, the first on the entire African continent, despite not being eligible for donor funding, to be the first on the continent to introduce both the pneumococcal conjugate vaccine as well as the rotavirus vaccine into public immunization programs. And when that introduction was done around about 2009, it was done at a time where the increase in expenditure for procurement of vaccine just for the introduction of these two vaccines increased 200%. So what we were able to demonstrate, because of local generation of data locally and applicable to the Southern African region, we were able to advocate for its inclusion into the public immunization programs. Now, unfortunately, there are challenges. So often one of the major challenges that we face when it comes to introducing vaccines, especially new vaccines into public immunization programs, is the demand on the part of authorities to generate local data. And unfortunately, many a time, and this is something that we try to avoid with COVID-19, many a time, the decision and the resources to actually do those studies in low and middle income country settings only becomes available after those vaccines have actually been licensed and start to be used in high income countries. And what that inadvertently results in is one of the reasons why there's usually a lag in the time period between when vaccines are introduced in immunization programs of high income countries compared to low middle income countries. As an example, with a Haemophilus influenza type B conjugate vaccine, it took 20 years from the time when those vaccines became available in high-income countries to when more than 70 to 75% of low and middle-income countries included the HIP conjugate vaccine into their public immunization program. Part of it was obviously related to cost issues, but other parts of it was there not been adequate epidemiological data, as well as not adequate data in terms of how well those vaccines would work in low and middle-income countries. And that picture, unfortunately, has actually improved. So when you look at pneumococcal conjugate vaccine, although not where we were wanting to be, it took close on to 15 years from the time when those vaccines became available in the United States in the year 2000 to when at least 80% of low middle income countries included it into the public immunization program. But rotavirus, somewhat of a different picture in that scale up of the vaccine usage in low middle income countries to some extent was actually much quicker than what actually occurred in high income countries. But the important message here is that hundreds of thousands of lives are lost each year when there's a delay in the introduction of life-saving vaccines into public immunization programs of low middle income countries where the majority of severe disease exists for many of these vaccine preventable diseases. Now, another field that I've been much more involved in over the past 10 years really relates to the field of immunization in pregnant women. And in particular, we've done studies around influenza vaccine. In fact, this was the first randomized control trial of influenza vaccine, which showed efficacy for protection both in the mothers as well as the babies. And the two people that I show you, Martha Nunes and Claire Cutlin, again, people from my research unit that were very core to this particular program, again, both alumni of the ADVAC program. Now, interestingly, with this particular study, one of the other important learning experiences is In contrast to what we saw with the pneumococcal conjugate vaccine, what we demonstrated in this particular study of interest was that although influenza vaccine probably causes a very mild burden of severe disease per se in young infants, what we were able to show is that when you vaccinate pregnant women against influenza, you can actually have a 43% reduction in hospitalization for all-cause lower respiratory tract infection in the babies in the first 6 months of life. And of all of these cases that were actually prevented, hospitalized cases that were prevented, almost none of them were actually due directly, almost none of them tested positive for influenza. And what we suspect happened here is that by conferring some level of protection against influenza infection in the babies, by having immunized their mothers, these babies were actually protected from developing a superimposed bacterial infection, which is the most likely reason why these hospitalizations were taking place in the first place and why there was a reduction in hospitalization in babies that were born to mothers that were vaccinated. Another important study, and something that I was quite passionate about when I was training as a pediatrician, and I'm sure anyone that's a pediatrician can fully identify with this, is a large number of children that are hospitalized year on year come the fall and the winter season for RSV. And certainly this is a field that I've been involved in research for close on to 20 years. So it was really, again, a privilege to be involved on the first RSV vaccine trial targeted at pregnant women to try to prevent illness in their young infants. And the findings of this study, interestingly, are somewhat mixed, in that although overall the vaccine efficacy in this particular study, which was a multinational study that included high-income countries, was only 41%, when the efficacy was analyzed specifically for South Africa, as an example, when looking at severe RSV LRTI in South Africa itself, there was a 75% reduction in severe RSV LRTI and a 62% reduction in RSV LRTI due to hospitalization. And again, one of the major drivers for this is probably a difference in terms of the clinical presentation of RSV in children in low and middle income country settings compared to high income country settings. So although at this stage this vaccine has not been licensed for use, I believe this vaccine, as well as other vaccines that are currently being evaluated, RSV vaccines that are currently being evaluated in pregnant women, have got huge potential in terms of being able to impact on morbidity and mortality, especially in the first few months of life. Now, unfortunately for you, you're not going to have the opportunity of being able to engage with the many other students and with the many other people that are actually attending the ADVAC course, and that comes at a cost. And the cost that it comes at, unfortunately, is ability to network. So included in this, which is from 29, membership of the WHO Strategic Advisory Group of Experts, and I was invited to be a member of this in 2019, is Andy Pollard, who's been a member of SAGE, and I think he's also lectured at the ADVAC course. And I was fortunate that I actually got to know Andy Pollard in the year 2000 when I actually attended the ADVAC course. And I think the ADVAC course has provided huge opportunities when it comes to being able to make contacts and network in the future. Many other people on this in this photo were also alumni of the ADVAC course, and others are lecturers, including, I think, Kathy Neels and Pieter McIntyre. Helen certainly are alumni of the ADVAC course. So the reason I show this is last year, around about April, May, I got wind of the fact that the University of Oxford were very much at the forefront of developing a COVID-19 vaccine. And having been involved in the space of research on vaccines, as I mentioned in the past, one of the biggest hurdles to the introduction of this COVID or to any vaccine into low middle income countries is a delay in terms of when the studies are done in these low middle income countries before you can have robust evidence to make a firm recommendation for introduction of the vaccines in those countries. So exactly about a year ago, I reached out to Andy and I asked him whether the University of Oxford would be interested in at least providing vaccine for us to do a clinical trial of the Oxford vaccine, which is not applicating vector-based vaccine in South Africa. And Andy was certainly keen, but indicated that unfortunately at that stage, and that is prior to them having agreement with AstraZeneca, that they wouldn't be able to fund the study, but they would certainly be interested in providing the vaccine. So I went about trying to raise funds, and fortunately we were able to raise funds. And that led to me being involved in the first two COVID-19 vaccine studies, efficacy trials that were done on the African continent. The one was with the Oxford vaccine, and the other one leveraging on my engagement with Novavax as part of the RSV vaccine trial. Again, I was able to convince them to consider doing an efficacy trial of their vaccine in South Africa at an early stage. The results from these two studies is something that I'm not going to go into the detail, except to say they were somewhat dissimilar, despite having enrolled a similar sort of demographic. And inadvertently, what happened with both of the studies is the enrollment into the studies occurred at a time when the first wave was peaking, or after the first wave had subsided, but prior to the evolution of the B1351 variant in South Africa, which we know is relatively immune evasive. And the net readout from the studies is that the Chadox vaccine, unfortunately, we were unable to demonstrate vaccine efficacy against mild to moderate COVID-19, and at least not vaccine efficacy of greater than 60%, whereas for the Novavax vaccine, we were able to demonstrate at least 60% efficacy, including against mild to moderate infection due to the B1351 variant. Now, has that assisted us in terms of being able to expedite the introduction of COVID-19 vaccines onto the African continent, including in South Africa? And unfortunately, the answer to that is a dismal no. When we look at what happened in 2009 with the swine flu pandemic, when the swine flu pandemic vaccine was actually developed within a space of about 3 to 4 months, leveraging on the platforms of seasonal influenza vaccine development, the swine flu pandemic vaccine became available to Africa. But it only became available to Africa after the pandemic was declared to be over by the WHO. And right now, we're sort of facing a situation where probably the vast majority of individuals in high-income countries, including children, who are at nominal risk of developing any meaningful severe disease from COVID, would be vaccinated, whilst close on to 98% of people on the African continent and many other low-income countries will remain unvaccinated. So this really calls into question the current model that exists, both in terms of the type of investment that exists on the African continent itself, to ensure that the African continent can become less dependent on manufacturers and companies outside of the continent, to have greater surety of security of accessing vaccine timelessly, more so in a pandemic situation. So right now, what we face in Africa is that of the 1.56 billion doses of vaccine that has been administered, only about 30 million of those have been administered on the African continent. And this shows you the number of doses of vaccine that have been administered per 100 individuals. In Africa, it's sitting at 2 per 100 individuals, in contrast to close on to 60 per 100 individuals in North America. So this sort of what is now being termed as vaccine apartheid, unfortunately, is very much a reality. And despite us having done those studies at a relatively early stage of the clinical development of those vaccines, we haven't been successful in leveraging on that to make a case for the introduction of COVID-19 vaccines expeditiously in the African continent and other low-income countries. And obviously, the reason for this comes to the issue of the quantity of vaccine that's available and the willingness of governments from high-income countries to bring about some sort of equitable distribution of those vaccines. Why do we find ourselves where we are in Africa? And the unfortunate reality is that there's limited manufacturing capacity when it comes to vaccines on the entire African continent. In South Africa, as an example, we don't have our ability to actually manufacture vaccines from the active pharmaceutical ingredient to the fill and finish spectrum. In fact, there's no vaccine that's been developed, that's been manufactured in South Africa for the past 20 years. In many other African countries, they've got very limited capacity and certainly nothing meaningful that would be able to be scaled up in a period of 2 to 3 years to ensure that they're actually able to become self-sufficient, not just for COVID-19 vaccines, but as well as a manufacturer of other vaccines. And what is the source of this? Now, one of the biggest challenges that we face, and it speaks to what ADVAC is all about, is the lack of adequate expertise. And the lack of adequate expertise, unfortunately, speaks to the type of opportunities that exist on the continent when it comes to training in the field of vaccinology. And this is a landscape analysis that we undertook. And Jennifer Moise is another alumni of ADVAC who assist us in this landscape analysis for those of you that might be interested. And we were able to identify a number of hurdles which prevents people from becoming competitive and people becoming interested in the field of vaccinology on the African continent. Now, included amongst that is that the type of research that takes place on the African continent, and this is over a 10-year period, is very much focused on epidemiological research as well as, to some extent, implementation research. But the spectrum of pathogens are largely biased and influenced by the type of funding that's available, not to people from Africa, but rather to the type of funding that's available to people in high-income countries to undertake research on the African continent. And this is a major, major problem. And there's no other way to describe it other than colonization of the research agenda on the African continent. So inadvertently, what ends up happening is that the type of research and the research focus area is not determined necessarily by the local priorities, but rather by the promoters of this research. And often the people that are doing this research in many, many of the African countries, unfortunately, are people that are affiliated to high-income country institutions doing research on the African continent. And to emphasize this point, and if you haven't read this, and you might not have read it because it only came out last week in Nature Medicine, this is an open letter discussing the need for a decolonization of global health and to address the type of imbalance in power of collaborations that currently exist. And an example that's used in this letter is that in the year 2017, as an example, 1.1 billion rand was allocated for malaria development aid by the United States, United Kingdom, and Canada. Of that $1.1 billion, only 1% of that funding actually reached the local in-country research institutions. 81% of that was used to support institutions in the funding country, which were high-income countries. So it comes as little surprise that there isn't sort of equity in terms of the ownership of the research agenda. And part of the reason for that is because Africa as a continent and its scientists haven't been able to establish themselves as independent scientists. And that comes at a cost. And that's the cost that we're really trying to redress. My little way of trying to redress this and having really benefited from my attendance at ADVAC, and I have to declare, my only formal training in vaccinology was actually me attending that first ADVAC course. To try to bring about greater capacity on the African continent, what we embarked on in 2016 was to actually have an iteration of ADVAC in Africa, which is known as Afro-ADVAC. And this is targeted at individuals that have had at least 5 years of experience in the field of vaccinology, be it whatever sphere. And over the past 2 iterations, we've now had close on to 120 people that have attended from close on to 27 different African countries. And unfortunately, the course that we were meant to host last year was postponed because of COVID, but that will take place in 2021. In addition to which, leveraging on this and all about building capacity on the African continent is we've now introduced at my own university a 2-year master's course in vaccinology since 2019. And as of this year, we'll be introducing a PhD in vaccinology at the university. And Claire Cutlin, who I mentioned is an alumni of ADVAC, is the scientific coordinator of this particular exercise. So to go back to where I started 21 years ago, again, like I said, I was really marveled by this notion of being called a professor of vaccinology. And fortunately for me, in 2008, I was able to convince the university to confer the same title. And it came when I was asked what exactly when I proposed this particular title, I was asked by the senior management in the university as to what exactly does a professor of vaccinology do, which speaks to its own in terms of what the standing of vaccinology is on the African continent, and including in a place such as South Africa, where we have higher education institutions that are amongst the top 200 in the world. So I guess my take-home message is that to quote someone that I hope everyone is familiar with, Nelson Mandela, the founding father of our democracy in South Africa, is that it always seems impossible until it's done. And I do believe that because of the type of initiative that ADVAC has initiated, because of the initiative that ADVAC is, which has really prompted us to try to mirror it in our own way, that it is possible for us to use this as a foundation to develop further capacity on the African continent. Thank you for your attention.
Thank you very much indeed, Shabir, for another quite inspiring talk. And actually, if I sum up, all three talks have highlighted very different career paths and different facets of vaccinology and some of these sobering challenges that vaccinologists face. I note also across your three talks the touch of optimism and very much realism as well, and the flagging of many challenges. So we are running a bit over time, but I think it is important to give the possibility to all of you to interact as you see fit with the three alumni who have presented. So don't be shy to throw any question, even personal ones. I see that Sean has actually written something which is a bit on the long side, but I will give you the possibility to speak, Sean.
Thanks. Yeah, I'm a lawyer, so it takes us 5 minutes just to clear our throat. So these are three interesting routes to the present, and I just wanted to ask a couple questions, one personal and one general. And so the one is for the ADVAC trained lawyer interested in stepping away from teaching privileged kids about contracts and that sort of thing, and wishing to contribute more directly to global architecture and to global health justice. Can you identify any opportunities that exist now or contacts with organizations that could be enabled? That's a sort of a personal instrumental question. And then more generally, what advice can you give us on how best to leverage our ADVAC experience to discover possibilities for making more profound and potentially more satisfying contributions, given that we've missed that chance to sort of explore these more informally through fostering friendships over the meals, drinks, and walks that we've been repeatedly told about during the last 2 weeks? Thanks.
So let's hear from all three of you, actually, very briefly in response to Sean's. We want to start, ladies first. Anne?
On the pathway, you know, I think, again, I'll go back to the first slide and follow your heart. You know, where do you want to be? What do you want to go towards, right? So, and explore the opportunities. It's not easy sometimes mid-career to change or go somewhere else, or, you know, build your CV to be apt to different international organizations or anything. But of course, you know, you can do it. It's a crowded space, and it's not always easy to get those entry points. I think follow your heart and find your right mentors along the way. And that goes back to your second question: leverage the ADVAC experience. Even if you may not have seen everyone here, the little I interacted with you, the group so far, it seems like you can you have had a pretty, you know, strong connection and good questions coming up, and you've seen and spotted your different friends here in the age group. Beyond the pandemic, there are so many other opportunities, like Madi was saying as well, Shabir was saying as well, of reconnecting with ADVAC people in different international meetings, courses, conferences, etc. And take that opportunity and find your mentor, and then go for it. Over.
Thank you, Shabir.
Yeah, I mean, I can't. I mean, look, I think COVID-19 and this whole discussion around TRIPS and IP rights, and you coming in as I assume a lawyer, is something which there's very little reason why we can't use the type of resources that exist in high-income countries to support this initiative that has largely been driven by lawyers in South Africa and India. So I don't think there's any sort of magic bullet in terms of how you can get involved, and it really depends on your individual passion in terms of looking at and then deciding what sort of opportunities exist to be able to feed into it. But I think in the immediate future, the big issue around COVID-19 vaccines is access. I don't believe that sort of a temporary relief of the IP rights is going to be the answer to making COVID-19 vaccines more accessible in the short term. Probably not the right fight to be taking on, but it's a principal decision, it's a moral decision. So not much else to add in terms of being able to provide guidance, and certainly nothing to add when it comes to how you can redress having missed out on the cheese, the wine, and the good food, and the friendships that would have been fostered had you attended in person.
Thank you, Shabir. Kamel?
Yeah, very briefly, I think they already, Anne and Shabir already said it, but I think, yeah, with your background, you would be probably very helpful to work with the new global health advisor at WIPO, the World Intellectual Property Organization. You would be very helpful with people working at CIPI, because they are doing all those contracts with developing countries and high-income manufacturers on how to transfer technology. I believe WHO is also working on that. And that's linked to the second question. I think you will have access very quickly to the alumni database that I mentioned during my presentation. And I believe Philip probably already presented this, but what I would do, and what I always did, reach out somebody which profile is interesting to you and ask this person for a coffee or for a Skype meeting or Teams meeting, or if you're going to a meeting, just check if those people are ADVAC alumni, and just go and ask them, I'm an alumni, I would like to talk, do you have time for me? Nobody will tell you no. So I think that would be what I would do for networking and getting connections.
Thank you, Kamel. And I see that in terms of connection, there was reaction from Boston and from Jinjing, saying that not having a face-to-face meeting, they missed a lot. But indeed, you missed Verrier, you miss food, but we try to make it and foster some interaction. And I think what we are hearing from the free alumni there is that there's no excuse not to network. I mean, you've started to network between yourselves. So it's in your hands to make it happen. And at the end, you may not have missed so much in terms of networking ability. I will now turn Shabir. Apologies for Shabir. He sent his apologies. He had to disconnect, but there are a couple more points. And I will invite now Yasmin to speak.
Thank you. Yeah, so I had a question actually for both Anne and Shabir, but I see Shabir has left. But I was really struck by your phrase to just come back better or build back better in the wake of the pandemic. And I'd love to hear your thoughts about what that could look like for maternal immunization specifically.
Oh, sorry. Thank you for that question. I saw it in the chat and I was just about to answer in the chat. So thank you for asking it again. I think that the world has never had its attention so strongly on primary health care and the importance of essential health services, including maternal and child health, including immunization, as it may have now. It's been living in a more of a hidden place we all know it's good, but we don't invest too much in it. I think that the pandemic has really showed the cost to it. I hope we are not going to experience measles outbreaks and others to even make us reminded again about it. But I think the years beyond now, we're going to see the consequences and then also use that as an opportunity for advocacy of changing the ship and build back better. There are also huge funding opportunities right now coming into countries with the rollout of the COVID-19 vaccine. So I see opportunities when it comes to using those, not just to do safely rollout of COVID-19 vaccines, but also to build back better. So you have logistic systems, you have cold chain systems that can be, assisting beyond COVID-19 vaccine rollout, the digital tools I talked about, and the training of healthcare workers, even seeing how the HR gap in many of countries seriously needs to be addressed, in low-income countries I'm talking about. Because we are going to see the lack, particularly not painfully now, but in a few months when the big rollout of the vaccine will be coming. So I think, so hopefully with that global attention and suddenly a realization that it's not taken for granted, it's an investment you need to do if you want to have strong systems in immunization. You need to invest on it. And it's not because it's cute, it's nice, it's because it's essential. It's because the best payoff is in immunization. And I think that this pandemic has really showed how everyone cares. Everyone becomes the champion of understanding immunization and the epidemiology around the COVID back, etc. But I can see that opportunities are also being created in the craziness of the pandemic. I see that the way we work between COVAX partners at the moment is pretty extraordinary. It's different from before the pandemic, because we have such a laser focus on what needs to be done, and that kind of tears down some walls, and people throw off their cap of their organization and just say, let's go get it, And I hope we can maintain that so we don't, go into our different bubbles afterwards again. And I think that's also an opportunity to create something better afterwards.
Thank you very much. We had one last question that we will take from Richard Shawana, and I think it was perhaps more addressed to Shabir, but considering that the two of you, Kamel and Anne, have worked substantially in Africa, perhaps you will want to provide some elements of answers. So, Richard?
So Philippe, I can start if you want. The question is regarding the vaccine, the manufacturing, right, in Africa.
Yes.
So first, that's a good point, Richard. First, the vaccinology expertise is needed. You cannot build manufacturing facilities if you don't have the entire environment around it. You need to have research, of course, but you need also to have regulatory authorities. You need to have markets. You need to have pool procurement. You need to have political interest into manufacturing. So I think all that is probably linked a lot to the availability of academic vaccinologists to populate and to do entrism to the different organizations in Africa. But then, regarding the manufacturing itself, there are already, and I don't know if it was discussed during this ADVAC course, but there are already countries manufacturing vaccines in Africa. Some have stopped, some have continued, but you have great examples like South Africa, Tunisia, Egypt, Ethiopia, I believe. So you have existing capacities that are limited, and they disappeared partly because of the costs and the fact that Indian vaccines were cheaper and Indonesian vaccines were cheaper. I believe that now with the political will and the involvement of head of states, African Union, African CDC, and some strong leadership, some countries are willing to reinvest. And I believe that the global community is also interested in reinvesting. There are, I mentioned CEPI new strategy starting next year. One of the big pillar of it is to encourage and to support tech transfer to ensure that those companies are able to produce vaccines, maybe using the new platforms that are less, I would say, complex than the usual vaccine production platforms, the usual cell-based manufacturing processes. So there are CEPI, WHO is supporting that. The Gates Foundation is also supporting that. I think now we are at a time that there is a willingness to move forward. The political will is there, but we are still probably missing a bit this, how to say, this group of vaccinologists that would support the entire process. So hopefully Africa is ready and is moving forward, and with the support of other partners, hopefully it will happen, but it will take time. It's not something you can do in 5 years. It takes much more time. India took a lot of time to do it. So China the same, Indonesia the same. So but I'm very optimistic. Over.
Thank you, Kamel. Anne, a very brief complimentary answer.
No, I just wanted to say that, and I see that already in the chat. So WHO is working very strongly on this right now, together with CEPI and other partners, and there is a lot of investment interest. So just like Kamal is saying, it's part of the building back better, right? So that we're not going to be in this painful supplies constraint, that the manufacturing sites will be multiplied in possibility for now, even during the pandemic, but then to be able to use those investment for later on other vaccine productions than COVID-19.
Thank you very much. And so a big thank to all three of you for these wonderful presentations and participating in this discussion. So it's very hard to clap when we are on virtual mode, but from the messages I saw, I mean, the participants seem to be very appreciative. So thank you very much, Kamel and Anne. And we will now move to both a fun part, the awarding of the prizes at the end of the course, and the sad part, which is in terms of closing remarks, although again, we will have tomorrow the media session. So it's a closing, so to speak, before the end. So let's before moving to the prizes, I want to stress that you really have been a wonderful group. You've been literally amazing. I mean, having 73 participants follow for 3 weeks and stay connected despite the duress, despite the challenges, despite some of you, clearly we saw that on video, being both driving and watching ADVAC virtual mode. That's really amazing. And I know that many of you had to basically take your job shift, which was really unfair, but probably needed for the people that you serve, and you also had your family duties. So it was really a lot, and I know that some of you had more duress than some others. But it was really a pleasure to interact with you, and I'm speaking on behalf of the entire team here. And it was very rewarding to see the engagement despite the difficulties. So we will now move to announce the prizes, and there were, as we said before, we would award 3 prizes for the best participation in the discussion, and these will be not yet, and we will first start with the announcement by Edwin of these 3 prizes, and then we will move to Sandra announcing another prize, and then I will announce the last prizes. So Edwin, please.
Thank you, Philippe, and greetings from now, Colorado. So I miss not being in France the last 2 weeks, although I came from Annecy to have rain here in Colorado also, so nothing different. Can I share my screen? Great. And let me just go to I'm in the right mode. Hello, Philippe?
Sorry, I muted. No, you are not quite in the right mode. You are in the dual mode, so you need to go up to the display setting and click.
There you go, right?
Yeah, perfect.
Perfect. So first of all, let me add to what Philippe have said. I think you're going to be labeled for now on as the ADVAC COVIDian class. And you're a unique set of individuals, as well as a unique group, especially because what Philippe mentioned, you, during the last year, most of you, if not all of you, have really been quite involved and led and worked hard to save lives like no other time that we have had. So we gotta recognize that many of you have been at the forefront of not only the development of vaccines for this pandemic, but perhaps also maintaining the research and the work that needs to be done for other life-saving vaccines. Many of you are doing several things at the same time, including clinical work as well as advocacy work, and again, it puts you in a different moment. And while you were taking ADVAC, because you were not isolated in Annecy, you continue to perform some of those those tasks, even though you already had done 6 hours of learning with us. I want to recognize, and normally, this time when we are at the castle, I usually recognize the class, and every class that we have had over the last 20 years has been improving in many ways. But I want to highlight your endurance and adaptability. I don't think we have seen ever a class that was so clearly committed to learning from the distance, even though the challenges that happens, and how you adapted in the last 2 years to even having been selected to one in the world class sort of a course to being adaptable to continue to be with us and become part of the alumni and this special group of people. So you always will be unique for all of us, and that is great. Now, having said that, I also couldn't finish without sort of showing your evaluations, and I have to say that even though you never recovered to the level that we have had in the past, I have to acknowledge that you did your best to sustain a level of evaluations that was meaningful to us. And I have to say that since I came from Annecy, I even saw that some of you went back several days to complete evaluations that you haven't completed, perhaps because you didn't have the time at that moment. There's still going to be time to complete, but in any way, I want to recognize that even this is probably a tremendous rate of return of feedback for the evaluation for a course that is kept online and at different times and hours that really make it challenging for completing those evaluations. There's one more evaluation coming, and that's the last evaluation. That evaluation we expect you and hope for you to sort of get a lot of feedback. You already, through this evaluation, have provided tremendous feedback to us, and we really appreciate how you participated even in activities like the mentoring sessions and so forth. So again, very special from that point. So now is the time to recognize those of you who contributed, we think that contributed through their participation and interactivity in the course. As Philippe has mentioned at the beginning of the course, we have 3 book prizes. We select the individuals using a secret formula that is safely guarded throughout the times in ADVAC, and therefore I wouldn't be able to disclose what the formula is. The only thing that I can tell you is that it has to do with the times that you ask questions, the quality of your questions, your participation, but also it has a meaning in terms of the formula includes what we call the correction factors that would allow us to sort of provide unique individuals that we think that will benefit from this prize a lot. So without further ado, I will start by announcing the 3 books or 3 prizes. One is what we call the Plotkin vaccine book. We call it the Bible of Vaccinology. The second is what we call the R&D vaccine book. That's editor is Mike Levine, and finally the Lambert vaccine book. And so those are three from faculty that you have had during ADVAC and who are special books for everyone to sort of have and treasure for their life. So let me first advance the Plotkin vaccinology book, and the book this year goes to Manoha Das from India. So congratulations, Manoha. Your book is going to be sent by Dr. Plotkin via, if I'm not mistaken, via courier. So we'll be in contact with you to provide that. I will like you all to applaud.
Thank you so
at the
much.
end.
Thank you so much, sir. Thank you so much, Edwin.
Perfect. Why don't you have, if you want to have a minute or so, I'm happy to open the floor.
No, thank you. I think it was a very challenging experience, but at the same time also really exciting. And to discuss and interact with the so-called legends in the field and get the real tough, and meeting so many friends and colleagues across the globe whom we are going to contact over the time and again. And that's what is going to remain as a memory for a very long time. Thank you all so much.
You're welcome and congratulations. The second book, or the second sort of prize, the R&D vaccine book, goes to Ileana Castillo from Canada. So congratulations, Ileana, for your participation, your active engagement with ADVAC. So I'll leave you the floor for a minute or so.